Hello, I'm Dr. David Levine, and today's date is April 29th, 2023. I'm in Chicago at the American Association of Plastic Surgeons meeting where I'm doing interviews for the ICON project. The purpose of the ICON project is to preserve in audiovisual format icons of our society who are teachers, innovators, forward thinkers, and great surgeons who advance our specialty. I hope you enjoy this. Hello, I'm Dr. David Levine, and welcome back. I'm here to interview Dr. Peter Neligan for the ICON project. Dr. Neligan, thank you for coming.
So nice to meet you. Thank you very much.
So my first question starts out, would you state your full name and date of birth?
Peter Camillus Neligan, July 20th, 1952.
And would you tell us a little about your parents, their names, and any association?
My parents were both school teachers. My father's name was also Peter, but it was the Irish version of Peter, which is Pather, and my mother's name was Rita.
Okay. And you said they were both teachers, correct?
They were both school teachers, and I went to their school.
Okay, and you were born in Dublin?
No, I was born in Cork, which is in the southern part of Ireland.
Okay.
And I grew up in Kerry, which is southwest of Ireland.
Right. And how many children and grandchildren do you have?
I've got 2 kids, 5 grandkids.
And would you like to state their names for posterity?
Yes, so my kids are Kate and David, and my grandkids, the oldest is 10, his name is Lewin, and then Milo, who's 6, Claire, who is 5, Audrey, who is 3, and Tess, who's 2.
Okay. Now, do they live over there, or are they in the States?
They live in Toronto.
Oh, okay. So you can get to see them.
So we get to see them. We have a place in Toronto. We live in Phoenix and Toronto. We spend the winters in Phoenix and the summers in Toronto.
Okay. And I was talking with Peter. You live in Toronto. Where do you live now?
We live in Phoenix.
In Phoenix, yeah. That's right. Yeah.
We
better climate.
I practiced in Toronto for 25 years. Then we moved to Seattle for 15 years, and then we retired in January 2021 and moved to Phoenix and bought a condo in Toronto, which we use in the summertime.
And your wife's name again was?
My wife's name is Gabrielle.
And how did you meet her?
Medical school. We were in the same class.
Oh, okay.
Yeah.
What inspired you to go into plastic surgery?
Oh, pure accident. It's actually a very interesting story because my wife and I were planning to get married at the end of medical school before we started our internship. And we were called into the office of the chairman of the board of the hospital, who said, it has come to our attention that you two are a couple. And we said, yeah. And he said, what are your plans? And we said, we're planning to get married at the end of our medical school before we start our internship. And he said, I'm very sorry to tell you, but the board will not tolerate a married couple among its intern staff, so one of you will have to go. And so we decided that it was easier for me as the male to get a job elsewhere. And they helped me get a job. So I ended up doing in Ireland, there was a compulsory internship, 6 months medicine, 6 months surgery in order to qualify for a full license. And so I did medicine in one hospital, and then I did surgery in another hospital. And it was the hospital in Dublin that had the plastic surgery. There were 50 beds of plastic surgery, and it was the only plastic surgery hospital, and it was the busiest service. And because I was the new kid on the block, none of the guys who had been medical students in that hospital wanted to do the plastic surgery rotation, so I got stuck with it. I had no idea what plastic surgery was, and 2 weeks in, I was hooked.
Isn't that serendipitous?
It is totally serendipitous.
Was who headed the program? Was anybody we would know?
His name was Brendan Prendeville. He was a wonderful surgeon, but he would teach you up to a certain level. When I was a junior, what they call a senior house officer, which is like a junior resident, I had my own operating room. We worked 3 operating rooms each day. He would be in one, working on private patients. The senior resident would be in another one, doing most of the public list, and then I would be in a third. And he would just say, just move the flap from there to there, and that was all the instruction I got. And then if I had a question, I would go into his operating room to say, sir, I need some help. And he would get a green towel and cover it over whatever he was working on so I didn't see.
Okay, I got a question. This is right out of medical school.
This is right out of medical school.
And you were doing surgery.
Yeah.
Wow. That's scary.
Well, no, that's not quite right, because we had to do full training in general surgery. So I had done, I'd done all of my general surgery.
All right, okay. So you got married out of in medical school, but
we
you
got
went
married right at the end of medical school in 1975. And then I did my general surgery training. And then after I did my general surgery training, I vacillated between orthopedics, pediatric surgery, and then ultimately plastics.
Well, who are your mentors in plastic surgery? Or any mentors? Doesn't have to be plastic surgery. Medicine.
One of the reasons I went into plastic surgery was that some of the other attendings and senior resident staff were really nice people, and they were real mentors. So there was a guy called Jerry Edwards who was one of the attendings, and he used to take me every Saturday. He would take me with him to a private hospital, and he would do breast reductions or whatever he was doing. And at the end of every Saturday, he would sit down and write me a check for my help.
Oh, wow.
One of my other attendings in general surgery was completely different. He used to bicycle everywhere. He fell off his bike and broke his thumb. And he used to take me to the private hospital, and he would get into scrubs, put his hand behind his back, go talk to the patients and say, we'll take very good care of you. And then he would go in the surgeon's lounge and read the paper while I did the operation.
What if they wanted to shake hands?
Oh, he said, no, I'm scrubbed. He'd make some excuse.
Oh, wow. That's interesting. That's an interesting story. Look, you're up in Toronto, right?
Right.
And then you went to University of Washington, correct?
Right. Correct.
I read an article that said they were fortunate that you were limited to 10 years in Toronto.
So the way Toronto works is that there's a limited tenure for leadership positions. So you can serve 2 terms. A term is 5 years. At the end of each term, there's an external review. If you pass your external review, then you can serve a second term, and then at the end of the second term, you have to step down, which is a very good system because it means that junior faculty who might one day want to be chief are going to have a chance, so they're more likely to stick around than move elsewhere.
Yeah.
And also, you have 10 years to achieve what you want to achieve. So people tend not to get stale. And I've seen it in programs all over the country where guys are chief for 25 years and they're basically just drawing their paycheck. They may do great things in the first few years, but then they get stale. So I love that tenure system.
I've seen that in the Supreme Court.
Absolutely.
But that's another story, isn't it?
That's another story.
Could you talk to the Canadians and see if Trudeau could make a phone call and help us out here? Your changes you've seen have been momentous. You and I are peers, okay? Right. I'd just like you to discuss that, the momentous changes, the paradigm shifts that we've had in plastic surgery.
It's been very interesting. When I trained, we used to do the head and neck resections as well as the reconstructions. We used to do all of the hypospadias, obviously cleft lip and palate, hand surgery. The scope was much, much broader because now urology does all the hypospadias, head and neck does all the head and neck stuff, including the reconstruction. But that's been pretty typical in what I've seen with plastic surgery as I've sort of gone through my career, is that we tend to develop solutions to problems, and we'll start to do them like head and neck reconstruction, and then another specialty comes on and starts doing it, and we say, okay, and we go off and do something else. Like the last 10 years of my practice, 80% of my practice was lymphedema surgery.
Yes, I read that.
Which is new, and which is incredibly exciting because it's a black box that we know nothing about, and it's going to be massive in our specialty in the next 10 years.
Elaborate on that, because what I remember is that you had 12-0 suture. That's pretty small. Yeah, what is it? Are you using it for? Chronic lymphedema, post-mastectomy lymphedema?
Both. Use it for both primary and secondary lymphedema. And what you're using that 12-0 suture for is for doing lymphatic bypasses, where you're connecting a lymphatic to a venule. And you want a venule that has a a competent valve system. So when you cut the vein, there's no back bleeding. Because if there's back bleeding, then the pressure in the vein is probably going to overcome the pressure in the lymphatic system, and it's not going to work. And so we use the 12-0 nylon for that anastomosis, because these vessels range in size between 0.3 and 0.8 millimeters in diameter. But now it's progressing beyond that, and there are two companies in existence right now who are developing robots specifically for microsurgery. The Da Vinci robot, which is ubiquitous, which is everywhere, it's too big for microsurgery. The instruments are too big and clumsy, and the company's not interested in developing them for microsurgery, probably too small a market. So there are two companies, one in Italy and one in the Netherlands, who are developing robots specifically for microsurgery and specifically aimed at sub-1 millimeter vessels. Because once you get to 0.3 millimeters, everybody has a tremor, but when you're working at 40 times magnification, which some of the new microscopes can go down to, that tremor becomes rate limiting.
An earthquake.
An earthquake. And so the robot can eliminate that.
Yeah. Well, that was, when I was starting, microsurgery was just becoming on the forefront.
Right.
Kleinert was doing it, and Kentucky, and all the different venues. But all I can tell you is I remember working under a microscope at 10 power and getting a headache.
Right.
Because it's a different world.
It's a different world, and now the more recent microscopes, the one that I use, and I have no interest in the company, but it's a Japanese microscope called Mitaka, and it goes to 40 times magnification. And that's 40 times magnification. You can't work under it all of the time. So you find your vessel, you figure out this is the one you're going to stitch, and you zoom into 40 just to get your stitch in, and then you zoom back out to tie the knot.
Yeah, but you make it sound easy. Finding a lymphatic vessel that size, it's not like the line on that wall. But we won't get into how you ferret that out surgically, because that has to be tedious in itself, and it takes a human to find the vessel.
It is tedious, but there are tricks to finding it, and those have been. That's partly what I've been working on for the last 10 years, is sort of making that surgery feasible and easier.
Okay. What do you feel is? Well, you've already said the most important innovation, you would say was microsurgery in our field.
It's one of them. Okay. I mean, there have been so many. One of the things that's fascinating, because I've been doing this 6-volume book, we're just finishing the upcoming edition, which will be published in October. And there are 34 new topics in that book, not just new chapters, new topics. 34 from the last edition, which was 6 years ago. Wow. That's amazing.
Yeah.
And some of them are combinations of things. For example, transgender surgery, particularly the facial feminization surgery, that's changed, and it's become a combination of craniofacial aesthetic surgery and incorporating things like fat grafting and stuff, all of which is relatively new. That you and I weren't fat grafting when we trained.
Right.
And fat grafting has been a huge advance, and it's used everywhere. And it's not just to fill in wrinkles. Gino Rogati, who's a surgeon in Italy, showed us that you can mitigate the effects of radiation with fat grafting. And I used it in my practice for example, patients who were radiation cripples from a lumpectomy with pain. Then you inject fat, and the pain goes away.
So, you think any of that has to do with stem cells too?
It probably does. The thing is, we don't really understand exactly what's going on. And we don't understand exactly what's going on in a lot of areas. For example, the whole lymphatic system, we don't understand. And there's now, 10 years ago, it was taught in medical schools, and it was thought that there were no lymphatics in the brain. And now we know that there are lymphatics in the brain. And the lymphatics have been implicated in, for example, the development of Alzheimer's, Parkinson's disease, because one of the theories is that the function of lymph, we know that the function of lymph in the body, in the peripheral system, is to wash junk out of the integument and bring it back to the lymph nodes. Well, it's thought that the same thing happens in the brain, and that if your lymphatic system is not working properly, then you accumulate amyloid and all the other things that have been identified. So it may well be that that may be part of the solution for
mechanical may be part of the solution.
Exactly.
Yeah.
It's just fascinating.
The plumbing.
The plumbing.
Yeah. Yeah.
It's fascinating. But the plumbing is tied into all sorts of other things. Like when the plumbing doesn't work, like in lymphedema, the plumbing doesn't work, but then the immune system in that limb doesn't work. And so these patients get cellulitis and then end up in the ICU with life-threatening infections. And it's not just simple plumbing, but plumbing may be the initial trigger that causes it.
Who at this point, and we'll move to the next topic, but I'm interested, so I want to hear, who at this point is the most forward-thinking researcher and surgeon that is promoting this at this point? I know you've retired.
Yeah.
So who is carrying the ball?
The guy who started, well, it started in the 60s with Julius Jacobson, who's a vascular surgeon. Bernie O'Brien in Melbourne carried the torch and was doing a lot of this surgery in the 80s, and it wasn't really working. But the guy who has really brought it to where it is now is a guy called Isao Kashima, and he's in the University of Hiroshima in Japan. He's the former chief of plastic surgery at the University of Tokyo, and the guy is he's a guru. I've known him for 30 years. I would meet at meetings. We'd go to the bar and have a drink, and he would start telling me his ideas, and I would sort of nod politely, and then I'd go to my room and wake up at 3 a.m. thinking, oh my God, he's right. And he's the guy who he started what we now call super microsurgery, which is microsurgery at a smaller scale where you're doing sub 1 millimeter vessels. And that requires not just new microscopes, but these new sutures, new instruments that are much smaller. The regular micro instruments are too big now.
Right.
So Kashima is really the guy who has carried the torch and led us in that, and he's still working. And there's a bunch of us around the world. We had a meeting last week in Barcelona. There's a bunch of us around the world who've been working on lymphedema for the last 10, 15 years. Kashima started us. I first started working with him in 2005. We were doing a flap course, and he did a lymphaticovenous anastomosis, and we were all saying, the hell is he doing? And we all scrubbed in with him at various times, looking down the scope, and he would say, oh, very important lymphatic vessel. And we'd say, what the hell is he looking at? But now we have techniques of finding these vessels and imaging them. And it's all become, aha.
And this is related to this, and you may remember, and lymphatics have been an issue.
Yeah.
Remember Noel Thompson?
Yeah.
Yeah.
Yes.
And everybody thought he had the answer.
Yes.
And I spent some time with him in London. An interesting guy. And they thought he had the answer to lymphedema post-mastectomy.
Yeah.
It didn't work out that way.
Right.
But again, in plastic surgery, we're always trying.
I remember stumbling on, in my fellowship exam for the Canadian boards, that was one of the questions I had. You remember his technique of grafting muscle into eyelids?
No, I don't remember that.
He devised this technique of grafting muscle into eyelids, and it was very complicated. And I remember being grilled by somebody who was obviously a fan of his, but asked me this question in my boards, and I thought I was going to die.
Interesting. Well, I think you've touched on this, but I'm going to ask you anyway to let you discuss it, your greatest professional accomplishment.
I think my greatest professional accomplishment has been getting involved in the 6-volume textbook that was started by Converse and then McCarthy and then Mathis, and then I took it over in 2008, and I'm just finishing my 3rd edition, and that's been very gratifying.
And a lot of the younger persons, plastic surgeons, have never heard of Converse.
Right.
Of course, that was our Bible.
Absolutely.
The 6-volume. And in fact,
it used to be 8
when I
volumes.
retired, and I may have bought the other 2 volumes as it enlarged. And I think when I retired, I gave it to another plastic surgeon because they could sit on my shelf, but I wasn't going to appreciate them like he would.
Right.
And now it's a historical text. And when I saw the picture with the 6 volumes, I thought, that's the next generation of Converse. Right. And that's a lot of work.
Because a lot of people, older people like us grew up with Converse, but then a lot of people grew up with McCarthy, And then those who are slightly younger than us grew up with Mathis because he did the next version. And then, like I said, for the last 15 years, I've been doing the last 3 versions. So it's
Well, I congratulate you on that.
Oh, thank you.
That's a lot of work. You were herding a lot of cats there.
it's a lot of work, but it's fun. It's funny because you send out these invitations to people to write chapters, and you go to a meeting like this, and you're walking down the corridor, and you see Joe Blow coming down, and he takes a turn because you know that he hasn't turned his chapter in yet.
I said it's like herding cats. Would I assume that that's been your greatest joy, or is something else you'd like to discuss?
No, that's been my greatest joy. I mean, I've loved surgery, and my practice has changed from the time I started. I started in a community practice in Northern Ontario because I was initially, after I finished my training, I went to the University of Toronto to do a fellowship, ended up doing 4 fellowships. And then during that time, I got offered a job at the University of Toronto, which I accepted. But the Ministry of Health in Ontario said, you're just a goddamn foreigner. You have to go to an underserviced area if you want to get immigration to this country.
Interesting.
So I ended up spending 5 years in Northern Ontario in a mining town. Then got recruited back to the University of Toronto and actually started, I was director of the burn unit in Toronto for a number of years. And then microsurgery was always kind of my first love. So I moved hospitals, moved to the major microsurgery center in Toronto. And when I was in Toronto, my practice was probably about 70% head and neck reconstruction. And then I started doing a lot of breast reconstruction. Then I moved to University of Washington. I wanted to continue to do head and neck reconstruction, but the head and neck guys didn't send me any cases. And the chief of head and neck, who's a friend of mine, sat me down and said, look, Peter, I'd love to get you doing the reconstructions, but if I get you doing reconstructions, then that's lost revenue for our department. And so then I got interested in lymphedema, and then my lymphedema practice just blew because patients with lymphedema have been used to going to doctors and being told that nothing can be done. So when they see somebody who appears to know something about it, then one patient told me that I was on 8 Facebook groups. They had all the, patient had these discussions and say, who should we go to? So I was getting patients from all over the country.
Wow. Yeah. So there's some good with social media.
There's some good with social media.
Not a lot.
Not a lot.
And one of the things that I read about you, and it was, if you could just touch on it, it mentioned that when you went to the University of Washington, it was a fledgling program. What does that mean?
So what had happened was that Nick Vedder is the chief in University of Washington, and there are 4 main hospitals in the university system. And the University Medical Center, which was where I ended up, was where most of the oncology was done. There were 2 plastic surgeons there. One of them left, leaving 1, and then he decided to leave.
In private practice.
So all of a sudden there was nobody to do the reconstructions. And so the university and Nick wanted to recruit somebody senior to build a program rather than just recruiting a guy straight off his residency. But to recruit somebody senior so that I could then recruit a bunch of people. So we ended up with 7 surgeons in that hospital.
Wow.
So that is another achievement that I'm very happy with and very proud of.
Was Jeffrey Marsh up there?
No.
Okay. I guess he was a chief. I thought it was up in that area.
Yeah.
I interviewed Dr. Vetters, by the way.
Yeah.
He's part of this icon
part of the deal.
project. Who would you say you admire most professionally or personally?
It depends on whether we're talking about somebody living or somebody
Anything. you just pick somebody.
One of the people that I admire that I was fortunate enough to work with, who's an amazing guy, is Joe Gruss. Joe Gruss is a craniofacial surgeon. I first got to know him when I was a fellow in Toronto, and he was an attending, but hadn't been an attending all that long. And at that time, he was working on. He would spend hours working on facial fractures, and he used to wire them all together. And then he ultimately developed the system that we now use for treating facial trauma. And he independently, and Paul Manson both developed our current approach to craniofacial trauma. And Joe was an amazing guy, and he's one of the reasons I decided to retire, because Joe had planned to retire. Joe was an avid golfer, and for about a year before he retired, he kept saying, next year I'm going to go to, he was going to go to every golf course in the world and just play it. And then we had a shindig for him at our resident graduation dinner. We had movies ready and awards for him for his retirement. And when he showed up, he wasn't his usual self. And we discovered that 2 days before that, he'd been diagnosed with inoperable pancreatic cancer. And so when I saw that happening to Joe, I thought, that could happen to me. It could happen to anybody. And so I decided to quit.
Well, I was supposed to interview him.
Right.
And then they wanted to do it on Zoom, but
Right.
it was too late by that point, which is kind of the purpose of this project.
Right.
Is I wish I had.
Yeah, he was an amazing guy.
You can't get everybody. Well, I want to know what your opinion is. Words of wisdom for present and future generations of plastic surgeons.
Oh, I think the most important thing is to do what you love. If you love doing something, you get good at it, despite yourself, and you basically never work a day in your life because it's all fun. My two kids, when they were teenagers, each said to me independently, driving into town or something, "Dad, you're crazy. There's no way I'm ever going to work like you do." And then maybe 10, 15 years later, again, independently at different times, they said, "I get it about you. You love this stuff. This is not work." And I said, "That's exactly right." So that's what you got to do, I think, is find whatever it is that floats your boat.
It's like the old story, when I went to college, my father was stupid. By the time I finished, he got smart.
Yeah, that's right. Yeah, I went through that from the time my son was 16 until he was about 20. I learned an awful lot.
And that's a common theme,
Right.
is that what we do is fun.
Absolutely.
It's not drudgery.
Right.
It's creative.
We're very fortunate.
Both sides of our brain get to work.
Most of the world goes to work and works in a horrible job to get enough money to pay their mortgage, and we're very fortunate that we don't have to do that.
Yeah. What words of wisdom have you found? You mentioned retirement, and when you realize the clock's ticking. Is there any words of wisdom for retirement for those that are listening to this?
Yeah, absolutely. Because one of the things I've discovered since I retired is that people are scared of retiring. Because so many people have come up to me and said, "How do you know you have enough money? And how do you fill your day? And do you not get bored?" And no, absolutely not. And one of the things that I hate to see is, when you come to a meeting like this and you see some old guy who should be sitting in a dock somewhere having a beer. I think it's very sad, and I don't want to be one of those old guys who comes back to meetings. And I think I always wanted people to say, "Why did you retire?" rather than "When are you going to retire?"
Okay, and it's funny, when I started this, I was working.
Right.
And then I retired.
Right.
So this question was because I hadn't retired yet.
Right.
But now I appreciate the answer that you gave, which is, I tell people, here's the deal. Retirement isn't easy. You're going to sleep 8 hours a day probably. You got 16 hours to do something. Yeah, you'll take a nap during the day. You'll do that. But find stuff that fills your day, that makes you happy. They're the things you always wanted to do. You play guitar. You do
right.
that. You say, "Hey, I don't." The hardest thing for me when I retired was, for the first month, I kept thinking, "What have I got to do tomorrow?" Then I put my clock in the drawer, threw it away.
My wife says, when somebody says to me, "So you retired?" My wife says, "No, he retired from income."
Yeah. Now we're on a fixed income.
Yeah, that's right. But the best piece of advice I ever got, which is, I think, worth passing on, when I was working in Northern Ontario, one of my mentors, a guy called Bill Lindsay, who's a former president of the association, he's the guy who gave the association the gold medallion. He had been chief of the University of Toronto, and he came up to Sudbury, which is the town I was working in. I was not there. He and his wife took my wife out for dinner, and they were trying to recruit me back to the University of Toronto. And at the end of dinner, his wife went to the ladies' room, and Bill was sitting with my wife. He said, "Tell that boy he's got to decide if he wants to live where he works or work where he lives."
Mm-hmm.
And that was, it took me a while to sort of figure out what he meant, but that was, I think, the best advice I ever got.
Yeah, yeah. So, last question. What do you see for plastic surgery in the next quarter century?
Oh, I think it's really exciting. I mean, that's one of the regrets about retiring is that I'm not going to be part of it. But I see huge advances. I think, like I said, the whole lymphatic thing is going to be huge. I think, the combination of all of the things we do, I talked about facial feminization, the combination of craniofacial with aesthetic, all of that's happening. The combination of craniofacial with micro, transplant. I don't think we're going to be doing lots of face transplants, but we're going to be able to, once the whole immunology thing is sorted out, we're going to be able to do things like transplant a nose. Like this, maybe half a dozen surgeons in the world who can do an exquisite total nasal reconstruction, and it takes 4 or 5 operations in 3 or 4 years to do it. Mm-hmm. Imagine being able to do it in one operation and hitting it out of the park.
Yeah,
we'll be
absolutely.
able to do it. We can't reconstruct functional eyelids very well. Imagine transplanting one that just works as soon as you plug it in. There's so much that there's so many possibilities. And one of the things that I worry about is that there's a tendency for people to sort of be nervous about the future and to just do the things that are current. For example, most of the plastic surgery meetings or a lot of the plastic surgery meetings I go to now are about breast reconstruction. We're going to lose breast reconstruction as a specialty, because if you look at the history, we've lost. Where we're very vulnerable is we're vulnerable in high volume procedures. Breast cancer is high volume, and we're vulnerable because we're not the gatekeepers. So a woman who has breast cancer doesn't come to a plastic surgeon; she goes to a breast surgeon or a general surgeon. That's how we lost head and neck. That's how we lost hypospadias. We're not gatekeepers, and we're very vulnerable in high volume situations. Yeah. And so I think we need to do what plastic surgery has always done, and that is to find solutions to problems that nobody wants to deal with. Because then that's going to be the sexy topic 10 years from now.
Yeah. Great. Well, Peter, this was a wonderful interview.
It was fun.
Thank you so much.
Thank you so much. Thank you very much.
Thank you. Thank you so much. And I hope you enjoyed this interview. All of my interviews are available online at meeting.aaps1921.org. I'll repeat that. meeting.aaps1921.org. And thank you.